We can start, sir.
Good evening, everyone. Myself, Dr. Suraj. Here is my case. 6-year-old girl, first by birth order, born out of non-consanguine marriage, resident of Malad, hailing from Bihar. Resident of Malad, hailing from Bihar, Muslim by religion, Sheikh by community, brought by parents with complaint of abdominal pain since 7 days, vomiting since 7 days, fever since 4 days, followed by yellowish discoloration of eyes since 4 days, and lethargy since 1 day. Patient was all right 7 days back when she developed abdominal pain, predominantly in the periumbilical region, intermittent, dull aching, non-spasmodic, non-colic, non-radiating. There is no aggravating or relieving factor. Followed by vomiting, 2 to 3 episodes a day, preceded by nausea, non-bilious, non-projectile, containing food particle, not associated with the passage of blood in vomiters. In fever, which is low grade intermittent type, relieved on medication. Child is active during interfebrile period, not associated with the chills and rigors. And there is a follow-up where parents also notice yellowish discoloration of eyes since 4 days, initially noticed in the eyes, which is gradually progressed to involve the entire body. Parents also noticed that the child was preferring to sleep, which is followed by lethargy and decreased oral intake. For this complaint, child was admitted in a private hospital where she received IV medication. Some blood investigation were done, and parents were told that child had some liver issue and was referred to for hospital. Uh, there is a history of outside food consumption and history of passage of high color urine present. No history of loose stool, no history of any drug intake, no history of any liver disease in the family, no history of blood transfusion, no history of joint pain, rashes, no history of bleeding from any side, melena or petechiae. There is no history of behavioral disturbances in the past, no history of burning, micturition, or cox contact. Past history, no significant past history or any similar complaint in the past. ANC history, uneventful. Birth history, full-term vaginal delivery. And there is no NSU stay, no history of neonatal jaundice. Child is immunized till 5 years of age and no special vaccines taken. Dietary history as child eats from family park. There is no calorie and protein deficit. Developmentally, child age appropriate milestone achieved, goes to score average scholastic performance, and belongs to lower socioeconomic class.
What are your initial thoughts on the history? Start thinking. Started with abdominal pain for 7 days and vomiting for 7 days. So that means for the first 3 days there was only abdominal pain and vomiting. So what would you think at that time?
Viral hepatitis.
That is because you heard the story later. I'm asking you abdominal pain and vomiting for 3 days. The fourth complaint means fever for 4 days is yet to come. Yellow discoloration is yet to come. How will you think in the first 3 days? Okay, food poisoning. So that's a thought. Now, what do you want in favor of that? What is not there here? So, what is a typical history of a food poisoning?
Loose tools will also be there, sir.
Okay, loose stools will also be there, but before that,
So,
Acute history, child will not take 7 days for vomiting. It will be sudden in onset post poisoning.
So he's made an important point that it will be sudden in onset. The whole illness onset will be in a few hours. And how many times would they vomit? His history is 2 to 3 vomits a day. In food poisoning, what would be the history?
10 to 15. 10 to
Many
15.
number of vomits, right? Then you said there may be loose motions. So thinking is right, but for these reasons, this is not food poisoning. What else? Okay.
Gastritis.
Okay, gastritis. So again, take it further. So first of all, why should a 6-year-old get gastritis? Start from that. Then what should be the typical history of gastritis?
History of drug intake.
Very good. So history of drug intake. Now drug is intaken for what? There has to be a reason to intake a drug, no? So is there any history before this, or this child was absolutely all right? Absolutely all right. So no reason to take a drug. What else? Where will the pain be in gastritis? What will be the vomiting type?
Epigastric.
Epigastric pain, then vomiting. Again, multiple vomits in a short period, burning, all that. What about acute GI infection? Dysentery or acute gastroenteritis? What are your thoughts? Do it ulta. Tell me the history of acute dysentery that you have seen.
Fever, loose stool, abdominal pain could be there.
So usually starts with high fever. Okay, then what about stools? Blood and mucus in stools. How many? Frequent, multiple. On over what time frame?
4 to 5 days. With treatment, two
No,
to
starting over what time frame? Means someone who starts with abdominal pain on Monday, can he have his first loose stool on Friday in dysentery? No. So all these things are very important when you start thinking of this abdominal pain and vomiting.
I think let's not jump to etiology and see what fits or doesn't fit. That's not the way to go about. First, tell me with these 3 days of abdominal pain and vomiting, where is the anatomy? We learned anatomy first in this medical college, no? You must start from that. Don't jump to say, can it be this? No, no. Where is the anatomy? If you don't know anatomy, you cannot proceed further at all. Then you could do all the tests and come to a great diagnosis. That's fine. So where is the anatomy? Come on, anyone.
Initial history of abdominal pain and vomiting points to upper GI tract. And after that, fever, and after that, yellowish discoloration is pointing towards extra GI, matlab liver.
See, in this child, abdominal pain and vomiting have come up together. Not vomiting coming later. Okay. So you would have said, I need much more information. How severe is the pain?
So you've
How
given
severe?
the history there. So take the features of the abdominal pain and see what is the anatomy of the abdominal pain.
Non-colicky, dilate, Okay, periumbilical, predominantly periumbilical, intermittent, but not quality. Which organ is involved?
So which are the organs periumbilical? Come on, which are the organs periumbilical? Small intestine, then mesentery, then pancreas,
So
then
largely periumbilical is intestine, rarely lymph node, and further rarely peritoneum. That's it. This is obviously not peritoneum. This is not obviously lymph node coming up in a short time. So it has to be intestinal. Okay. But a typical story of an intestinal disease is not coming up. So what does it mean? It's not an intestinal inflammation or infection, but it could be a beginning of some indigestion. Okay. That's why there is no significant symptom. It's a mild pain, no much typicality. Okay. And what is vomiting 2, 3 times a day? All that suggests there is some indigestion. Now, when it's indigestion, it's either in the stomach or in the pancreas or the liver. Now, if it is intestine, really in the stomach, you would have symptoms of stomach vomiting, but this vomiting is just 2, 3 times a day, and pain is not epigastric. So this is unlikely stomach. Could it be a pancreas? Pancreas usually is an acute onset severe pain. This is not severe pain, so it has to be the liver. Okay. Now this is the way you come to the liver as an anatomy. And then you ask questions further. Has there been a significant loss of appetite? Severe anorexia? Okay. If not, this is unlikely to be a viral hepatitis because there is no prodrome. So now we are looking at a liver. Till 3 days, jaundice is not evident, but it's a liver disease and it's an acute liver disease. Acute liver disease still proved otherwise will have jaundice. So we are waiting for jaundice to come. Okay. And therefore, this is unlikely a viral hepatitis. And in hepatitis, typically viral, there would be a prodrome. Other hepatitis are not acute in onset, the infective hepatitis. So this doesn't look like infective hepatitis. If it is not infection but a liver disease, then what else? Could it be an autoimmune hepatitis? Again, fever would have been very prominent, therefore less likely. And the third is, could it be metabolic? Yes. This suggests me a diagnosis of a Wilson's disease. Now, I'm far fetching that. I'm not diagnosing Wilson's only on this slide. But first, I told you how to arrive at a liver. Then I told you three common conditions of an acute onset of liver disease are infection one, autoimmune second, and metabolic third. If first two are unlikely, you can't rule it out, and we will see how the whole thing progresses. But therefore, till proved otherwise, 6-year-old put it as Wilson's as the most common metabolic disorder. I think that's the way to go by. Now take it further. You and pass it on.
So, sir made a point that this is non-infective based on this history, means not infective viral hepatitis. So, did you get that significance that how the sequence of events or what has come first or what is not there makes a difference, right? So, in typical viral hepatitis, there is extreme anorexia, extreme nausea. So, that we'll have to ask. Did you ask whether this child was eating well or no?
Loss of appetite is there, sir, but nausea and vomiting is not that.
Loss of appetite came up when?
Followed by illness, post abdominal pain, and vomiting.
Again, what I mean is that once the jaundice sets in, there can be loss of appetite. But as sir said, the prodrome, that means before the jaundice sets in that phase, how is the child feeling? That is what gives you a clue to whether this is viral hepatitis or no. Okay. Now, what about the fever? What do you make out of this description of fever?
Part of prodromal phase, low grade.
Is it infection? Fever is infection till proved otherwise. Is this infection?
Could be infected.
Could it be infection?
Sir, it is low grade, so may not be. If the infective, then it will be viral infective, then it is high grade. But 7 days history is very acute for a tuberculosis.
Every infection in a healthy child starts with fever. Infection is out. If your history is right, healthy child should start with fever in every infection. Fever can't come after 3 days. No question, low grade, high grade, whatever. This cannot be infection. Even if it was high fever, it was not infection. Look at the sequence of events. So if it was not infection, could it be inflammation? Again, most of the inflammatory disorders have high fever to begin with. Well, exceptions are there, but mostly are so less likely. So again, then what's the cause? Non-inflammatory, okay, and non-infective cause of fever. Does fever come without inflammation or infection? And the answer is yes. Any tissue damage leads to production of cytokine to which the body responds. And therefore, it is always mild. It's never severe. Severe is infection, severe is inflammation. But many things. A child of an asthma who has got a localized bronchial inflammation often says, थोड़ा गरम लगता है, low grade fever. Okay, but not. So this is some destruction. Gives you one more item to discuss. It's an acute liver disease with destruction of hepatocytes. What is it? Everything acute is inflammation, infection, metabolic. Go back again to the same, right? Everything is there. When you are talking about low grade fever, rest of it is not required. Low grade fever, the fellow is always all right. There is no interfebrile period. And there is no chills and rigors with low grade fever. So don't just like a robo give all that history. Take a note of it, right? Low grade fever does not need any further discussion. All right.
Okay, then there is jaundice, and then parents noticed the child was preferring to sleep, followed by lethargy and decreased oral intake. So, what do you make out of this? Just your thoughts. So, pointed question: is the child getting encephalopathic? Is this whatever is the original illness, has it led to encephalopathy?
It could be weakness due to uh, illness. That child is not.
Yeah, you're right. So now what history or how do you fish out on history that is it just the weakness of the illness or is it encephalopathy? Anybody? You got my point, no? Because you are worried in a acute liver disease whether he's getting into hepatic failure. So how will you differentiate the two?
Altered sleep pattern.
Altered sleep pattern is in chronic liver disease and that is the chronic encephalopathy. This we are talking about acute liver disease. So in acute liver disease, How will you differentiate? What questions will you ask? So when parents say that child is preferring to sleep, would you like to ask some common sense questions?
Suppose I find one of you sleeping just now. What's my first question? Did you have a severe emergency? Last night you were working? Then that's normal. Okay, so what questions would you ask? Come on, one of you, start talking. Doesn't matter if you're wrong. Learn to talk.
The child is he taking orally or not? If he's sleeping the hours of sleep, how many hours he's sleeping, or if he wakes up, is he active, or if the parents can find he is not behaving as before.
Very good. So one important question is, okay, he's sleeping more, but when he gets up, how is he? Is he bang normal? This is not encephalopathy, right? So that's one. Second, how easy or difficult it is to wake him up, right? So
He falls to sleep again. If he's encephalopathic, it's difficult to wake him up. He gets upset, and then you leave him. Next minute, he's back again to sleep. First thing is, most of us during acute illness are irritable but not drowsy. It's bothering me. I have pain, I have vomiting. What's happening? 4 days, I'm not well. Okay, I'm irritable, I'm frustrated, I'm not drowsy. But so we have come to a conclusion this is very likely pathological drowsiness, which means now so-called liver disease is entering into a phase of encephalopathy. What does it mean?
Metabolic cause.
I want you to say is fastly progressive disorder. You're right. But how did you come to that? Fastly progressive liver disorder.
okay, now history of outside food consumption present is means again what questions do you want to ask? Why did we ask this history? You're right in asking why did we ask?
To rule out infective cause like viral hepatitis.
So now which food consumed when will cause viral hepatitis? So yesterday I ate out in a restaurant and today these symptoms started. Is it viral hepatitis? So we read stupid things like incubation period, which we forget. Correct? So in viral hepatitis, that outside food is very least useful types because it has to be a few days back and you don't know how many days and you don't know how relevant it is, right? So this is more important for a acute disturbance than history of passage of high colored urine is, so it is conjugated jaundice. And then all these. Okay, so some of them are from the etiology point of view, some of them are from the complications point of view. Fine. Fine. So now at the end of all this, what is your summary? Then we'll come to his summary. There's nothing else in the history. So would one of you or collectively you want to summarize? 6-year-old, unhealthy child or healthy child? Healthy child. Starts with a, no, we don't want repeat of symptoms. Now we want our analysis. So starts with a acute or chronic, hepatitis or gastritis. Hepatitis. So starts with a acute hepatitis, which is infective or non-infective. Non-infective. Slowly progressive, mild, moderate, severe. which may be fastly progressive with possible complications. What are the possible complications? Encephalopathy, which we are not sure. We'll find out. So therefore, if you add all this, what is the possible differential? Yeah, acute liver cell failure, yeah, but due to what? Acute viral A, fulminant viral A. Sir said, na, metabolic cause is higher than a infective. We are saying it's non-infective. Can it be chronic liver disease? Can it be first episode of autoimmune hepatitis? Try, try.
It could be autoimmune hepatitis given the sex of the patient, and we should ask for more information about other extrahepatic manifestations like joint pain and rash, which is not there in this case.
Yeah, but they need not always be there, no? But still, any more discussion or argument for or against autoimmune hepatitis?
It is too acute in onset.
Very good. Then even the intensity seems to be a bit too much, too fast. And then fever may be higher. Okay. So those are the points. So we are not 100% saying no, but at the same time, there are some points which in a typical autoimmune, we see it differently. Right? Okay. Come, tell us.
My impression is a 6-year-old female child, first by birth order, born out of non-consensual marriage, brought by mother with complaints of abdominal pain, vomiting, since 7 days, and yellowish discoloration of eyes, followed by lethargy with history of outside food consumption. In a developmentally appropriate, completely immunized child is most probably a case of acute viral hepatitis with query hepatic encephalopathy to rule out, secondly, to rule out Wilson disease or drug-induced or autoimmune hepatitis. Actually, child is deteriorated now admitted in PIC. On examination, child is sick looking, drowsy, a febrile pulse rate of 100 per minute, respiratory of 20 per minute, BP maintained at 15 centile, saturation 99% on room air, extremities warm, ecterus present, there is no pallor, edema, lymphadenopathy, clubbing or cyanosis. Anthropometry wise child is normal. On head to toe examination, head face, oral cavity normal. There is no alopecia. Ecterus present in, and spine genitals normal. Abdominal distension present, and there is no other signs of liver cell failure. On systemic examination, per abdomen examination on inspection, generalized distension of abdomen present, flying fullness, no dilated veins, scar, sinuses seen, umbilical central planes and inverted. On palpation, soft tenderness present below the right subcostal margin, abdominal girth of 48.5 centimeter, liver 5 centimeter palpable below right subcostal margin, which is soft, regular borders and smooth surface, and right subcostal tenderness present. Liver span of 11 centimeter and spleen not palpable. On percussion, shifting dullness present. On auscultation, bowel sound present. On CNS examination, child is drowsy. Pupil bilateral equally reactive to light. On tone power reflex is normal. There is no asterisks, no meningeal signs, and CVS and RS system within normal limit.
So what did you gather from examination? What findings and what is the interpretation?
And it is soft, so it goes a bit against underlying metabolic disease. It's supposed to be firm.
Yeah, so any diseased liver is firm only.
Okay.
So it is not that it goes against a particular etiology. What it probably means is that our calling it soft is wrong. It is not soft. Okay. So all pathological livers are firm only. Only the normal liver is soft. So that's one. Then what else you got on examination?
And on CNS examination, he's drowsy, and we'd like to expand, investigate further into that. He's always drowsy or intermittently drowsy, or how much active he is. Depending upon that, we can consider the patient whether he's going into stage 1 NCAP or not. And
Okay. What else? He has ascites, no? His abdominal distension, shifting dullness, all that. So that makes it chronic liver disease. So we were all wrong in our discussion till now. What do you think? So anything against chronic liver disease in the examination? Anthropometry is absolutely normal. 111 centimeters for 6 years. Perfect height. Okay. So, and history wise also absolutely no complaints in the past. So then why ascites? So rarely or occasionally acute fulminant hepatitis can give you ascites. It's not common, usually in acute, but it can be seen if it's acute fulminant.
I think largely for every such thing, you keep in mind an acute viral hepatitis with fulminant course. So the question is, normal viral hepatitis never has a fulminant course. It's self-limiting. But if there is a liver disease, silent, then it might flare up to be worsening suddenly. Which are the silent liver diseases which the patient doesn't know because he has no complaint and the doctor doesn't know because he has no positive findings. So we must look at whether there is any possibility of such a silent liver disease. Okay, which are such? We did once nutrition, malnutrition liver, obesity liver. Both are abnormal livers. Next is a drug-induced liver. Somebody was taking anti-TB drugs or an anti-epileptic drug. The liver is not normal. Okay, though for all practical purposes, liver is maintaining, but it's not the normal liver, to which virally can just spread into failure. And the third is a silent hepatitis B antigenemia. It's good idea in an exam to ask for such a history. Malnutrition is ruled out, drugs are ruled out. What question would you ask to suggest whether the child could have a silent antigenemia with HBV? That would add. If somebody tells me in an examination, I would give him a gold medal. We are preparing you for that, so don't worry. Okay, don't pass just. Aim at that. Give a thought. I want you to ask the mother whether she has hepatitis B antigen in her test.
History of blood transfusion or history of any needle prick.
Whether she has taken any hepatitis B vaccine. She must not have taken because that time probably it was not there. But hepatitis B vaccine has been with us for last 30 years. So, but I'm just giving you a thought. What more? And now, if it is metabolic, what questions should you have asked the mother? History of consanguinity. History of liver disease, yes.
Yeah, so consanguinity definitely for Wilson's, etc. Bad obstetric history is more for congenital infections, torch infections, etc. Right? Yeah, so these are the double insults. So something is there underlying, and on top of which you get a viral A or a viral E or whatever, and that behaves differently. It behaves more fulminant than usual. So these are the other situations.
And that's why the hepatologist would order HAV, HBV to be ruled out in this case. Whereas a person like me would say, mostly it's ruled out, but they want to be only the rarest thing to be picked up. They're right. Okay. And therefore, we cannot be sure, but less likely. Why less likely? The syndrome to begin with did not look like an acute viral hepatitis. And then that fulmination has taken up suddenly on day 4, day 5. But first 2, 3 days, I was apparently all right. That's not a viral doing suddenly, right?
My impression is a 6-year-old girl child, first by birth order, born out of non-consensual marriage, brought by parents with complaints of abdominal pain, vomiting since 7 days, jaundice since 4 days, and lethargy with history of outside food consumption. In a birth and development, a normal child, immunized till death with tender hepatomegaly, and ascites with a developmentally inappropriate child, completely immunized. Anthropomorphic normal child is most probably a case of acute liver failure with grade 1 hepatic encephalopathy, secondary to rule out acute viral hepatitis, Wilson disease, autoimmune hepatitis, and drug-induced liver failure. These are the lab reports. On CBC picture HB of 12.5, hematocrit 14.4, total counts of 8,700, which is a mix. Platelets of 1,60,000. HGOT, HGPT arrived in 5,704 and HGPT of 1,970. CRP 23, prothrombin time of 29.1 and INR of 2.6. Total protein 6 and albumin 3.8. Total bilirubin of 6 and direct bilirubin 4.9. Serum ammonia 64, which is slightly rise. Random blood sugar is 36.9. Serum alkaline phosphate is 235. Electrolytes are 134 and 3.3. Uh, CBC picture tells there is no infection, counts are normal, and there are enzymes are elevated, which is suggestive of liver parenchymal involvement.
Yeah, but how elevated? So what more does it tell you? Is it extensive involvement? Is it
100, 5,000, 2,000. Does that mean?
Sir is asking, suppose your SGOT is 300 or 500 versus 1000 versus 5000. Does it make any difference to you in your interpretation?
Severity and extent of liver which has been involved, the number of hepatocytes which has been actively inflamed, and this suggests a fulminant course.
And what happens if it is 300, 500? Less hepatocytes are involved. So less fulminant virus. Come on.
Sir, SGOT-PT in thousands usually indicate hepatotropic viral infection
Very
or
good.
can be hypoxic injury to the liver.
Very good. So, but the reverse is also very important. So, SGOT-PT in hundreds is non-hepatotropic. So, therefore, it is secondary hepatitis, either due to enteric or due to some CMV or Epstein-Barr or whatever. Means a general viral infection, but not your Hep types. So, that is important.
I think enzymes high is acute. bilirubin, extent of the disease. So this is an acute, but to begin with, milder disease, which is worsening metabolically. Okay, so that's thing. But I wanted to comment on OT and PT. Look at that. OT is 5,700 and PT is 1,900. What is your inference out of that? You have not talked today.
PT is liver specific. Uh, OT is more raised than PT. Hemolysis would also be, we can consider.
What she said is PT is more specific to liver, yes. But that what does it mean? It's a systemic disease with liver involvement. Whereas the typical primary hepatotropic viral disease would have been much more than OT. So what your statement is right. Okay. But OT is general. So tell me where all general this enzyme is coming from. PT mainly the liver. Now where is OT coming from for you to say it's not specific but it's general?
RBCs, uh, m- muscles.
Excellent. And even the intestinal mucosa. So RBC, so many. So this looks like a systemic disease with a liver involvement. That goes fairly against a primary liver disease. Okay. See, we put pros and cons. We will quarrel it. Investigation should include HIV or for that matter even HBV. But so far with this, it is Wilson.
Why is protein? How do you interpret proteins? Liver disease albumin is 4.9.
Acute. Albumin is chronic. Bilirubin is extensive. Enzymes is acute. Okay. So that says that no chronic. But if it was a hepatitis B carrier, you will have normal proteins because the liver is not affected, but selectively getting some problem with total liver function, but not production, maybe some metabolism, but nothing more. Waiting to get worse with a viral agent. All right.
What about prothrombin time?
The synthetic function of liver is also affected. But protein, albumin are relatively fine, so the process is acute.
So why is it not showing in the protein yet? Takes time, no? Albumin half-life is long, so therefore it will take some time.
UFG A plus is such on normal ecogenicity of liver with thickened gallbladder and with moderate ascites. You have dengue, malarial parasite, and typhoid dot, which is also negative. Anti-HIV IgM and anti-HIV IgM.
Ifidot is given up even in India. So don't ask for typhoid at all. It's to be banned. Okay. So examiner will not accept your saying I'll do typhoid. Okay. Like not Mantu for TB. Well, Mantu, not Mantu for TB. I grew doing Mantu for TB. Why no Mantu for TB?
Latent infection. Manto indicates latent infection, latent TB, not infection. Can be positive even if in the immunized child.
Mantu positive, yes. Mantu negative maybe in TB. Okay. But it's one of the parameters, no? If you don't have infection, how can you have a disease? Mantu indicates infection. But to have a disease, you must have infection, no? It's a good test. And the reason is in epidemiology like ours, are many more without TB has a man-2 positive. That's why we have given up man-2 for diagnosing, right?
Uh, it's true that albumin will take a little longer time to fall, but there is ascites, there is hypoalbumin because just because of hypertension, portal hypertension, and there is not much of time for hypertension, nor is there any splenomegaly. It is little difficult to explain presence of ascites in a normal serum protein. I would have expected albumin little lower, maybe 2.8 or something for this degree to have ascites. Otherwise, the real crux of the thing of this particular case is first three lines. 7 days of abdominal pain, which was not localized, and then the occurrence of. If you could analyze that well, the, because those three lines ruled out so many things, including acute hepatitis, all those things. And simple analysis was those three simple looking sentences, which were probably very non specific, turned out to be most specific.
Diagnosis yet to madam. We have sent
What else have you sent?
workup for Wilson disease, serum ceruloplasmin 24-hour urine copper, and fundus examination is normal.
Slit lamp.
Not done yet, sir. Child is in PICU.
Okay. And so when you said child worsened, what happened?
Serum by child deteriorated, and even next prothrombin time and INR was also deteriorating.
You gave vitamin K.
Yes.
Still, there was no improvement.
If the child was given vitamin K and INR didn't improve, means what? So what? How does it matter? Sometimes you can have an INR which is higher prothrombin time, which is higher, but absence or failure to for prothrombin time to come to normal, having provided vitamin K is more. That means given the basis for manufacturing vitamin K, prothrombin, the child was not able to the synthesizing function. So more important than just a abnormal INR. Failure of the INR to come to normal after giving vitamin K is a little more important.
I think in an acute liver cell failure, there would be ascites with a normal protein. Because protein, albumin is a manufacturing issue. So it takes time to build up. And therefore, we said that albumin going down is a chronicity. Therefore, in many acute liver conditions, you will get a hepatocellular failure with encephalopathy, bleeding, ascites, but not very low, significant hypoalbuminemia. This is borderline kind of, and therefore that may not go against liver disease because manufacturing takes time. Would you have acute liver cell failure without jaundice?
Usually, no.
We already had said earlier, bilirubin rises when 80-85% of hepatocytes are damaged. So in an acute rash syndrome, in 24-48 hours, the liver goes bad and child comes with hepatocyte failure, but there is no jaundice as well. Just to give you an analogy, like albumin takes time to go down, a bilirubin takes a little time to come up. And much before that, on either situation, you may have an acute liver cell failure. You just keep that in mind. But there would be mostly a liver bypass. There is a reason. And again, An acute liver cell failure is a metabolic liver cell failure. That's what Rice syndrome is. In 24-48 hours, the patient comes from the onset of first symptom in an encephalopathy, but still not jaundice.
Any other questions?
Can
Slightly raised secondly. Six. Sorry. At present, there is no requirement.
actually, if it is a Wilson, the only thing that can save this child is an urgent liver transplant and nothing else. Luckily, he might come out, but not otherwise. But my question was, can ceruloplasmin be normal in such a Wilson's disease? And the answer is, if there is a significant inflammation because of hepatocytes are damaged, the ceruloplasmin may not be low and it could be still normal. In which case, how would you diagnose Wilson's?
24 hours urinary copper and liver biopsy.
It's a non-specific thing, and therefore you're right. Okay, it could still be any hepatitis because it's not only the Wilson's. So then what next? And that you will not do. And that is the final diagnosis is the copper in a dry liver tissue. But you won't risk it, that at all.
Talking about the hemodialysis for this child, often the treatment for acute liver failure more than hemodialysis is exchange transfusion. Now, it is not discussed and done well, but I remember days about 30, 40 years back, we had at least 15 cases of acute liver disease due to acute viral hepatitis, both in adults and children who had undergone exchange transfusion. The outcome was variable, but at least in the beginning, immediately after the exchange transfusion, the recovery was remarkable. Some of them did not sustain the recovery, but if at all there was any treatment at that time, it was exchange transfer. And doing exchange transfer of adults means you draw the blood from one side and put it in the other side, one hand here, and then unlike what we do in children. I've done a few exchanges in small children for this, maybe two, three, but could not save.
Okay, so we'll stop this case here. Any of our online friends want to say anything, comment, or ask any question?
Uh,
Yes,
Sir, actually,
Yeah.
the gastroenterologist used to say, particularly when the SGOT is more than SGPT, it indicates more of a Wilson. Why? Because it indicates a hepatocyte mitochondrial involvement. That is mainly more of a Wilson's, particularly when SGOT is more than SGPT. Like systemic disease, SGOT is more. Even in Wilson's, specifically, they say SGOT is more because of the hepatocyte mitochondrial involvement. This is the way usually the gastroenterologist used to say.
Yes, Palni. Yes. Any other questions or comments or anything from our online audience?
Rajesh, can I make a point?
Yes, Anjali.
Yeah, with such high INR, like Dr. Amdekar said, I think only liver transplant is going to save this child.
Correct, correct. Yeah, fine. I think we move on to the second case for today. And for this case, next time, please tell us what is the outcome of the Wilson's workup, etc. What happened, right? Yeah.
Like you all, I need your advice on something I'm going to say. Sir, मला तुमचा सल्ला पाहिजे. Like you all, I was an innocent resident. I got hepatitis A. It relapsed. I luckily survived. My colleague died. What is your choice? Will you take a vaccine or will you go like me? There is no policy. Government is not bothered. Our teachers are not bothered. They do not know. They are not aware of the problem. You have the highest risk of getting hepatitis A. So you have multiple options. In USA, you have to go. You have to show that you have antibodies to measles, mumps. Forget about. So check yourself. Do you have immunity for hepatitis A? Otherwise, you take hepatitis A. You get good salaries, right? You buy shirts, pants, which are not required. Take this vaccine and tell this to all. Once upon a time, we were told that after at about 10, 11 years, there may be not much of role for hepatitis A vaccine because by then you are already hepatitis A immune because the contamination, so-called contamination was so rampant that you would invariably get exposed to small doses of hepatitis by immune, maybe immune by 10, 11, no longer. Now we have the culture of mineral water drinking all the way. And I won't be surprised if many of us still don't have IgG or IgM, any one of them. As you said, and hepatitis A is relatively a milder disease in children, not so much in adolescents and adults.
Good evening, sir. Myself, Priyanka. Is the screen visible? 3.5-year-old
One
boy.
sec, one sec. Online is the screen visible?
Yes, yes,
Yes,
yes.
Okay.
sir. Yes, sir. The screen is
Okay.
visible and
Yes.
audible also. Please
Okay.
go ahead.
Yeah, yeah. Yes.
3.5-year-old boy, first by birth order, born out of non-consanguineous marriage, hailing from Allahabad, resident of Bhiwandi, Muslim by religion, Ansari by community, brought by mother with complaint of fever since 1 week, increasing cervical swelling since 1 week, vomiting since 1 week, abdominal pain since 1.5 months. Child was apparently all right 1.5 months back when he developed cervical lymph node swelling, noticed 1.5 months back. Size had uh, size increased initially and then decreased according to the mother, but increased in size since 1 week. That is from fever onset. Abdominal pain is not non-specific. At non-specific site on and off without any aggravating and relieving factor since 1.5 months. Fever high grade 102 degree Fahrenheit, not associated with rash, not associated with chills and rigor, partially relieved with medication but persistent. Child was not active in interfebrile period. Vomiting 5 to 6 episodes since 6 days. Non-bilious, non-projectile, not associated with blood. 3 days back, 3 episodes of greenish colored vomiting, not associated with abdominal distension. Child with above complaints was admitted in private hospital. Child developed 3 to 4 episodes of greenish colored loose stool, followed by small quantity, multiple episodes, lasted for 2 days, associated with foul smell, not associated with blood. Post hospital admission. History of edema at hospital since 1 day, gradually progressive in nature, started from lower limb up to ankle, progressed to upper limb, up to wrist and face. History of red colored tongue, strawberry tongue, according to the private practitioner. Received antibiotics, referred to Sion Hospital for further management. History of decreased oral intake present. History of oral ulcer. History of irritability. History of recurrent respiratory tract infections present, requiring nebulization. No history of rash. No history of decreased urine output, hematuria, or burning micturition. No history of COX or COX contact. No history of cough, cold, breathlessness on exertion. No history of insect bite. No history of jaundice or bleeding manifestation. No history of outside food consumption. No history of photophobia or convulsion. No history of eye irritation or redness of eyes. Uh, Past history, previous 4 admissions. First admission at 1.5 months of age for bronchopneumonia plus acute gastroenteritis, received antibiotics. Second admission at 1 year of age for 1 day in view of fever with acute gastroenteritis. Third admission at 3 year of age in view of acute febrile illness with severe urticaria, was advised immunology workup for allergy. Fourth admission in view of bronchopneumonia at 3.5 year of age, received antibiotics for 7 days. ANC history, registered iron folic acid supplements taken, history of low BP, oligohydramnios present, USG scan is told to be normal, birth history, full term, LSCS in view of oligohydramnios, birth weight 2.5 kg, baby cried immediately after birth, no NICU stay, no neonatal jaundice, immunized till 1.5 year of age, developmentally normal, dietary history, calorie deficit of 150 kilocalorie and protein deficit 2.3 gram per day. Family history, uh, there is one death of sibling at day of life 3 due to meconium stain liquor. Uh, uh, intubate the child was intubated. Anthropometrically normal. Weight is 12.2 kg, which is in -1 to -2 standard deviation. Height 96 centimeter, 0 to -1 standard deviation. Head circumference 49 centimeter, 0 to -1 standard deviation. Mid upper arm circumference 14.8 centimeter, -1 to -2 standard deviation. Weight by height -1 to -2 standard deviation. Anthropometrically normal.
Okay, wait. Go back. So this 3.5-year-old boy has come with a cervical swelling for about 1.5 months. The initial history, we are not very sure. Mother said it increased, decreased, and then again it has increased now since about a week. So what would be your first approach to that? And then we'll take the subsequent history. There is a lot in the history to be discussed, quite ups and downs. Come on, thoughts for a cervical swelling 1.5 months.
Can be a lymph node swelling, sir. Can be due to any cause, can be like acute tonsillitis or and also it is associated with abdominal pain since 1.5 months. Both have same onset. Abdominal pain and cervical lymphadenopathy. Mm. Can
So one point you said, whenever you see a cervical lymphadenopathy, so to cut it short, we'll not talk of other neck swelling. So we'll say mostly cervical lymph node. First approach is to look for any focus which has given to rise to that swelling. So you said tonsillitis is one example, but there could be many other. So look for a focus. If there is no focus, then what do you do? And what do you think? The abdominal pain is related? If it is related, how could it be related?
The the abdominal pain was non-specific, on and off. So,
So she is not very sure. That history was not very prominent. So you don't know whether to give a lot of importance to that history or no. So in such cases, it is useful to ask whether abdominal pain was there even before this whole thing started. And at least half the times you'll get a history, that's there since 6 months, 1 year. Then it becomes kind of unrelated, non-specific, some other cause, constipation, etc. So that's one way to decide whether it's relevant to this history or no. Okay. Now, if that lymph node is there without a focus, what do you do next? What is your thought process? You do CBC, MAN2, ESR, X-ray chest to rule out tuberculosis, right? What? Yeah. Just now we said we don't do mind to and you've forgotten. Hello, what do you do? So chest X-ray. So for every lymph node, you'll do a chest X-ray.
Antibiotic trial.
Any other thoughts?
Since there is no local cause and TB being very common in our region, so we will rule out TB first.
How?
Screening chest X-ray we will do.
So chest X-ray normal means no lymph node TB.
Then biopsy. FNS.
I think I'm not sure whether this was a single lymph node or there were some multiple lymph nodes. Now, that's the first thing I would have asked. Okay. Second thing is, it's for 1.5 months. Then what's the progress of it? We have said again and again, origin, duration, progress. So has it been increasing? But we are told in that last line, last but one, that the lymph nodes had decreased. Have all lymph nodes decreased? Okay. But we imagine some lymph nodes had decreased, but again increased. What is this happening? Have you seen a lymph node decreasing and increasing? So what does it suggest? I'll give you a clue. Have you seen any symptom which comes and goes and comes again and goes again? Then we will say whether it is similar to lymph node. Come on, you must talk.
When the lymph node were noticed by mother, maybe that time we were on.
Is the disease off and on? In TB, fever is off and on. Is the disease off and on? Then why fever is off and on? Does pneumonia have fever off and on? Meningitis has fever off and on. Then why TB has fever off and on, but the disease is on? Any thought? This is because that's an immune response to mycobacteria and not the multiplying bacteria. Haven't you seen urticaria coming and going back? What is the cause? Immune mediated. Right? So anything that comes, disappears and recurs is immune till proved otherwise. So you got a second point. This lymph node is a manifestation of an immunological disorder. What are immunological disorders? Immune deficiency, immune reactive, which could be infection induced or autoimmune. Or third, immune disorganized or imbalanced, which is called malignancy. So now can it be immune deficiency? With the history that you have given, can it be immune deficiency? What do you think?
Can be a primary immune deficiency because recurrent infection, past history of admission, past 4 histories of admission, recurrent respiratory tract infection, acute gastroenteritis. Can
Good thought. But if the immune deficiency started almost at birth, 1.5 months, then it was a very serious immune deficiency, often T cell or combined, and that could have just gone worst. Therefore, it is not possibly, probably an immune deficiency. You are right because of frequent. Now, which child doesn't get such frequent illnesses, but they're short lasting?
So in these kind of illnesses, you should always ask details about hygiene, bottle feeding, breastfeeding, all that nutrition, all that. And this bronchopneumonia is a little vague diagnosis we always discuss. So your history, what happened that time? Was there high fever? Was there low fever with heavy breathing? Even wheezing episodes could be wrongly labeled as something vague like bronchopneumonia. And then we will take it as a big infection and immunodeficiency. So that's the error that we have to.
And again, whenever you are looking at immune deficiency, ask what was the response to vaccines, and especially the live vaccines. Okay. So this looks less likely immune deficiency. Could it be infection induced? There is no evidence of infection. So two things are out. Could it be autoimmune or could it be malignancy? We are between the two. Autoimmune rarely comes with only multiple lymph nodes. It comes often with fever or joints, skin, but not multiple lymph nodes. But lymph node could be a part of autoimmune disorder. Okay. Typical Kawasaki comes with one lymph node there. So lymph nodes are known to be a Still's disease, what earlier used to be called, is also lymph node. So we keep that in mind, but malignancy a little higher up. Now, why malignancy? Multiple sites. Which malignancy? So why not TB only? Because TB we said is an immune manifestation. Okay. So by chance the lymph node seems to be going down. Okay.
Any thoughts on whether this can be TB?
TB less likely because no history of weight loss, anthropometrically normal child. Uh,
And acute
Any other
TB,
thoughts? To talk of cervical lymph node TB to begin with, and then you'll get your answer whether this can be TB. How do you normally see cervical lymph node TB?
localized, right? One single lymph node may be increasing, not multiple lymph nodes. Okay. And therefore TB is not likely. If the history is multiple lymph nodes, it's not. But then could there be an abdominal lymph nodes as a cause of abdominal pain? What is your take on that?
Possible, sir. We usually see abdominal lymph node and pain persisting, dull pain, abdominal pain.
One question to you is, when does abdominal lymph node start causing pain? Any idea?
Means how does a lymph node cause pain? Abdominal lymph node.
His cervical lymph node comes with a history of pain. So if there is tenderness mild on pressure, but not pain. He said, don't touch there, there is no pain. But when you touch there, there is a pain. So when does an abdominal lymph node cause pain? Only when the lymph node enlarges to a large size where the capsule of the lymph node is stretched, and then only there is a pain. And that often comes with a lump in the abdomen rather than just pain in the abdomen. But we keep all that in mind, right?
Sir, probably peritoneal involvement should be the cause of pain. That's the only structure which has, so to say, sensory supply. So if the lymph node has involved peritoneum, then probably it should give rise to pain and might serve as a localization also.
Only thing is that peritoneal pain is a sharp and acute pain. Where no, so lymph node pain is a very chronic dull ache pain. And that's why you're right. Appendicitis, yes. Okay, starts with the periumbilical, which is not severe pain, but goes to the right iliac fossa, very severe. So possibly This is not peritoneal. This is not even lymph node in the abdomen because it has to have time to grow to almost a tennis ball size, capsule stretch, and then pain. So by and large, that is the thing.
Now, this child is running fever for last 7 days, which is high grade 102. All that description is given, and child is not active in interfebrile period. Rigor associated with chills and rigor, and partially relieved, and all this vomiting. So, what do you make out of this now? Seven days of 102 fever with chills and rigors.
It may be the lymph node which may cause vomiting. It may enlarge to that size. It may cause pylospasm and vomiting. And there's also 3 episodes of greenish colored stones. Vomiting. It may point to obstructive, it's greenish and bilious.
So, intestinal obstruction due to lymph nodes.
Yeah, maybe.
Okay. So, what is there which is against obstruction?
No abdominal distension.
So, one is no abdominal distension. So, that is surprising, right? But what about the fever?
Fever is high grade.
High grade, yeah. What I'm trying to say, see, whenever you look at fever, start thinking, is it infection or no infection? If infection, acute infection, chronic infection, bacterial, viral, that flow chart should keep going on in your mind every time. So what I'm asking is, look at this description of fever for 7 days. What do you think this fever suggests?
It is infectious.
Okay, which
For
kind
7
of
days.
infection? Viral or bacterial?
The child is dull during interfebrile period
Hmm.
and
So
most likely
bacterial
bacterial.
infection. Where is the bacterial infection? Which organ? Brain, heart, lung, abdomen.
Most likely abdomen. And also there is mention of red tongue. Can be.
No, red. See, red tongue will come too. That's why we are trying to discuss and learn how to think. So,
I'll give you a clue. This fever has come at the end of several weeks. Why are you talking about infection? We are asking about this child, no? The fever seems to be the end stage of whatever this infection or whatever illness is. Infection is out. Will lymph node get a secondary infection? No. Why not? Everybody gets secondary infection. No? To get secondary infection, you must have a stagnant secretions. Sinusitis, okay, cholangitis, UTI, stagnant, okay, or immune deficiency, but we thought less likely in this child. And therefore, this fever is inflammation and not infection. So we go back to what we said, not autoimmune, not infection induced, not immune deficiency, so malignancy. What malignancy? Now it's simple to guess. What malignancy? Multiple lymph nodes above the diaphragm, below the diaphragm.
so they said lymphoma.
Yeah. Hodgkin's. Okay. Now we'll have to see what comes out, but this is the way to go by, right? Yeah.
In general, also as a fair observation, in a child of 3.5 years, lymph node in the neck as a tuberculosis manifestation is relatively uncommon. Usually older children, 6 years, 7 years, 8 years children, 2, 3 year old child with cervical tuberculosis is not very common.
I think, as we said, that Kawasaki-like disorder can come with lymph nodes, but It is not going on for a long time. Okay, acute onset, yes. So possibly it's not autoimmune. It must be possibly malignancy as the first probability.
And now the child has developed green colored loose motions, multiple episodes lasting for 2 days, foul smell. And this is after getting admitted to a hospital. Yeah, yeah. Before this, vomiting for 6 days, out of which terminally it was bilious, but without abdominal distension. And now all these loose stools. So what could this look like? This does look like a acute intestinal infection, but whether it's a separate entity or whether our details are not correct, I don't know. And then history of edema, which is gradually progressive in nature, started from lower limbs up to ankle, progressed to upper limbs up to wrist and face, and history of red colored tongue. So now this edema, is it like a big prominent edema or just a mild swelling, or how was it? Any description?
Not very prominent, mild to moderate.
It progressed over how many days?
Since one day, it was developed when he was admitted outside hospital. Since one mother says since one day the edema developed up to ankle and wrist, and in our hospital it was progressive and then decreased over uh, 4 to 5 days.
Even after admission here, the edema did increase. Okay. Any thoughts on that?
Actually, the intestines also has lymphatics. So let's continue talking same thing about lymphatics, and therefore could this be a spread to the intestinal lymph nodes? We're not talking about just a large lymph node in there, but in the intestinal wall itself. If that is so, then there would be intestinal symptoms, and these are intestinal symptoms. You said vomiting was blood stain, okay, a bile stain, but it was not bilious. Two things are a bit different. When there is a severe vomiting, you could have a bile. There is some greenish stools also, right? Greenish stools means the child is starving. That's why bile is not used. So this child seems to be starving, and therefore we will not give a lot of importance to bile stain vomit as an evidence of an intestinal obstruction, because the abdomen distension is should have been there, unless the problem is right at the third part of duodenum, and there even then the stomach would have been distended to some extent, but that's not easy to pick up. So only uh, bile stain vomiting due to obstruction without abdominal distension is a duodenal obstruction. We keep that in mind because the lymph nodes would press, etc. So I would carry the same thing further and say that some immunological disease is coming up, which is that autoimmune, less likely to my mind, malignancy, higher on card, but both can almost similar, like Kawasaki and other MISC. They both look alike, but the pathology is different, the immunology is different. So we keep immunological disorder in mind.
About that strawberry tongue, all of us know one cause of strawberry tongue, right? Or you know two. One cause you know of strawberry tongue or two?
Kawasaki and scarlet fever.
Which one is this? Is this Kawasaki? Is this scarlet fever or is this something else? Come on, we are just thinking. We are just learning via thinking. Nothing about being right or wrong. Okay, rash is not there. What else? Okay. So incomplete Kawasaki. So main thing what you would have said is the whole illness is 1.5, 2 months, 1.5 month from the beginning. And all this, as sir also said, fever much later in the disease. So all that is not the way Kawasaki we have seen. It starts with fever, right? So unless you dissociate the two totally, it is not possible. And therefore, many of these manifestations are immune mediated even otherwise, meaning in scarlet fever also you get that strawberry tongue, which is a sign of immune mediated damage or inflammation, right? So that way.
And I think red tongue only means there is a mucosal inflammation over the tongue. It doesn't say one way or another. But one another point is when we are talking about immune mediated disorder, it could be overlapping three types that I talked to you about. For example, HIV is an immunosuppression, but could have presentation like a Burkitt's lymphoma. A Burkitt's lymphoma is a malignant tumor, but the baseline is immune deficiency. So many of these immunological disorders are overlapping, and therefore we are not able to separate out what started and what is ending, but looks like an immune mediated disorder. Come near everyone. I think we'll make him first teaching. आप यहाँ बैठिए हाँ? आप यहाँ लेके बैठिए कुछ नहीं करते बेटा आप यहाँ बैठ जाओ कुछ नहीं करते हाथ नहीं लगाएंगे ओके anyone please present it to me after now even I make mistake where is the problem come. Very good come start talking like we said it or not shape growth development nutrition anything that's coming
So, male child, comfortably sitting, well nourished, um, um,
Averagely nourished.
slightly irritable,
Sick looking.
sick looking,
He's quiet, but he's sick. Not a happy child.
Mm.
Child would be interested in surroundings, looking at each other, looking at us, maybe a little apprehensive. He's not bothered. He's in his own world, maybe sick child. He does look sick, not very sick. He's a sick looking, averagely nourished child.
Mm.
What about pallor, any visible thing, edema, since we were told about that.
edema or lower limb present.
Okay, before that, do you think he's tachypnic? There is no obvious distress or alaneza working. We don't know whether he was tachypnic. Probably not. Or if at all mild tachypnea, we may not be.
Mild
No,
tachypnea.
yeah, mild tachypnea. No distress. We can actually count and see because impression may remain impression.
Mm.
Then you,
No.
since the complaints are about the cervical lymph nodes, बेटा इधर देखो, ये बाजू देखो.
No visible swelling.
इधर था कि आगे था? Maybe only mild fullness here, not much here where there is usually, perhaps over here. That also, since we are told that we are full aware, usually there is a The depression here, and that depression has not gone, but the fullness has come on the sternocleidomastoid and a little behind, more like a posterior cervical lesion, maybe small lymph nodes, not very sure. More likely to be small multiple rather than a big node. Now come down. Do you think the hands? Is he pale? He's coughing. He has a wet cough. Do you think he's significantly pale? Maybe pallor to a certain extent, but pallor to consider primary hematological disorder may not be there. Here he looks a little more undernourished than our impression in the beginning. Okay. Yeah. Abdomen
Looks distended.
slightly distended. What about the umbilicus? ऐसे जरा दिखाओ. Slightly stretched, but one does not know it is stretched because of pressure from within or not really. Yeah. And look at the lower limbs. Is there edema?
Doesn't matter.
Yeah, it is likely to be a
So
pitting edema.
he will cry probably. So we will make it short. Okay. कुछ नहीं करेंगे बेटा, कुछ नहीं करेंगे.
There's no organomegaly. There is no tenderness. No. I cannot.
Liver is 1 centimeter soft, no splenomegaly, but the feel of the abdomen is not normal. This is definitely a soft but a resistant abdomen. Just with gaseous distension, I should not have so much of difficulty in going down. I reached almost up to the posterior abdominal wall, but I could not find because the lymph nodes may be very deep seated, but I could not find anything. And he was particularly not tender at a particular part, but definitely the abdominal feel is not normal. It is a soft and a resistant abdomen, like something which we used to call as doughy. May not call that otherwise. And he had definitely peripheral edema, no significant pallor. He had a wet cough, but we didn't hear the chest sign. Here there may have been something which is dissolving. A little bit of fullness on the right sternopyramid and a little behind that, but not over here. So posterior cervical mode. Left side we couldn't see properly. Nothing else was there. No significant pallor, probably no icterus. No obvious swelling anywhere, no joint pains, nothing, no rash. Here there was a lot of problems inside. Stomatitis. I thought there was a thrush also, some white areas, but nothing more.
Yeah. But I was almost expecting large lymph nodes everywhere, etc. But maybe they are, yeah, I don't know, axilla or.
And baby being treated
Yeah,
now.
yeah. Good.
On examination, a febrile heart rate was 130 per minute, rhythmic, equal on both sides, regular, no radio femoral delay. A respiratory rate 30 per minute, peripheral pulses well felt, extremities warm, capillary fill time less than 3 seconds, BP 100 by 60 millimeters of mercury at 50 to 90th centile, edema up to ankle and wrist, cervical lymph nodes present, multiple enlarged, firm, non-uniform surface, local rise of temperature present, tenderness present, 3 to 4 centimeter, no redness, restricting the neck movements, bilateral inguinal lymph node present of size 0.5 to 0.5 centimeter, no pallor, icterus, cyanosis, clubbing, head to toe examination, head normal, face no facial dysmorphism, oral cavity, erythema present, angular cheilitis and stomatitis present, uh, tongue, reddish colored tongue present, upper and lower limb edema present, genitals normal, skin normal. Systemic examination, CNS, irritable but consolable, no cranial nerve involvement, tone increase in all four limbs, winces with movement, power moves all four limbs, reflex, knee reflex 3 plus, ankle, biceps, tricep reflexes 2 plus, plantar withdrawal, neck rigidity present, Kernick sign present, no sensory nerve involvement, no cerebellar signs. Per inspection, abdomen normal in shape and size, no dilated veins, scars or sinuses, palpation, superficial palpation, soft, no tenderness, a deep palpation, liver palpable 2 centimeter below right costal margin, along mid-clavicular line, soft inconsistency, non-tender, with soft margins, liver span 5.5 centimeter, spleen not palpable, percussion, tympanic note present, auscultation, vowel sounds heard, respiratory system and cardiovascular system, no abnormality detected. Diagnosis 3.5-year-old male child with fever, tender cervical lymphadenopathy, edema with history of recurrent respiratory tract infection, with oral ulcers and strawberry tongue with neck rigidity and Kernick sign positive. In anthropometrically and developmentally normal child, most likely a case of Kawasaki disease or scarlet fever, tuberculosis with complication of meningitis or malignancy.
So why do you say Kawasaki disease?
Sir, high grade fever.
It starts with high fever.
And irritability is a hallmark of childhood.
She says he's irritable.
Extremely irritable in the first 3-4 days.
But what kind of lymphadenopathy you get in Kawasaki? In Kawasaki, we get tender lymphadenopathy. How many lymph nodes? One or many?
Unilateral.
So unilateral single lymph node. Okay, we don't get multiple lymph nodes. And
Has the BCG scar been little prominent? Did you see that? There is often exacerbation of BCG scar in Kawasaki. Did you see that? No. Okay.
Could somebody trace how does the Kawasaki present to us in the first 3-4 days, second 3-4 days, second week, third week? That's a sequence of events. You can't say that the child had fever. The child had fever at the end of 5 weeks. So if I ask you what is Kawasaki, starts with high fever, minimum 5 days. Okay. At which time, what else are the findings? You get my point? You trace how Kawasaki comes.
Also, the exfoliations, periannual, So it starts with very high fever and irritability. And the irritability and which is non-specific, but child is really irritable. Lymph node may be there, which may be often unilateral and not bilateral. And there may be exacerbation of BCG scar.
then what happens to the eyes? What happens to the tongue later?
But what is the hallmark in the first 5 days of fever? All that comes a little later. And first 5 days, you may not have anything at all worth looking at. Okay, your conjunctivitis, purulent mouth, okay, lymph node, skin rash, all that is going to come up a little later. Which symptom comes in the first 5 days? And that is irritability. Younger the child, much more the irritability. That's a hallmark of a young Kawasaki. Of course, then there is a typical Kawasaki. But how atypical can it be? Can the fever come after 5 weeks to be atypical? Probably not. Right? Then you, of course, then you trace on to lymph node coming up, okay, cheilitis, stomatitis, conjunctivitis or purulent, skin rash, all that is to follow. And then at the end of second week, third week, you have also the exfoliation coming up. So that is the story of a Kawasaki. This doesn't look like that. It doesn't look like scarlet fever also by that.
Why scarlet fever? Why do you think? You think scarlet fever is a DD here, or I don't argue, just say no, because we're not jumping on her. We're discussing the differential. So tell me why you think scarlet fever is not a DD.
Lymph node swelling for 1.5 months is not usual presentation, sir. Usually comes with sore throat, cough, and fever, and then lymph nodes, acute onset,
No,
rash,
scarlet fever.
scarlet rash.
What kind of rash?
Is it only I can't hear or anybody can't hear?
Can't hear.
Sir, your audio,
राजीव
sir.
ऑडियो नहीं आ रहा है. Yeah, they heard us.
Sir, we cannot hear you. Tokhani, sir, we cannot hear you. Your audio is mute.
No audio.
Yes, sir. Tokhani, sir, your audio is muted. Hello? Hello? Sir, your audio is muted.
Not able to hear you, Rajesh.
Rajesh, we can't hear you.
Sir, your audio is mute.
No, we cannot hear.
Hello, no audio.
Rajesh, we can't hear. Rajesh, we can't hear.
Sir, your PPT is visible now, but
Yeah,
no audio.
yeah. We had lost connection. Now it's audible.
Yes, yes, yes,
Yes,
yes,
now
sir, you are
clearly
audible.
audible.
You are
Yeah.
audible. Yes. Thank you, sir.
Okay, so now tell us the investigation.
Um, complete blood count. Uh, on 3 to 25 Feb on 3 Feb 25, WBC was 8,500, and 25th Feb 25th March 19,000 pounds. SP was 14.3, 14.5, and 25th March 10.7. HCT was on 3rd Feb 41.8, RBC count on 3rd Feb 5.53, MCV 75.6, MCH 26.2, MCHC 34.7, platelet 231 2 lakh 31,000. And on 25th March, WBC counts were raised 19,000, HB of 10.7, HCT 34.8, RBC count 4.7, MCV 74, MCH 22.9, MCHC 30.9, and a platelet count 6 lakh 18,000. All are on 3rd Feb, total bill 0.4.
Just tell us the main ones which are important today. We will see the comparison of 3rd Feb, but what is important today, you tell us.
25th March, total bill 0.6, SGOT 19, SGPT 26, total protein 5.2, albumin 3.2, globulin 2, BUN 11, creatinine 0.6, ALP 113. CSF study was done, CSF RM, total leukocyte count 48 cells, poly 3 and lympho 45, protein was 52 and sugar 37. Cox workup done, MON2 negative, ESR 127, GL, gastric lava gene expert awaited, chest X-ray registry of hilar lymphadenopathy, HIV negative, 2 no abnormality detected, CT brain no abnormality detected, CSF CS no growth, blood culture no growth, CRP 371. And USG local neck was done. Multiple enlarged non-necrotic, two partially necrotic conglomerated lymph node noted in right level, second, third, and fourth, with largest measuring 1.82 into 1.3 centimeter in right level 2. Multiple subcentimetric size non-necrotic with preserved hilum noted at level 1B, second, third, fourth, and fifth, largest measuring 0.8 into 0.4 centimeter in left level 2. Underlying muscle vessel appears normal, thyroid gland appears normal. So features suggestive of infective or inflammatory etiology.
Any thoughts on the investigations? What are your thoughts? No, they're not done. Lymph node biopsy is not been done.
The whole story starts with lymph node, and you have an access. So that would give you a much better diagnostic term. Okay. I think overall tuberculosis must be considered in this, but the story of an intestinal problem looks very different. Okay. Edema coming up so early in the whole course, that means that the disease is very fastly progressive. And tuberculosis of this kind is not so fastly progressive. So both sides you have a lymph nodes, but how often one has seen tuberculosis in 1.5 months coming with hypoalbuminemia? That looks very unlikely, which means to me the disease is fastly progressive. And if it's vastly progressive, then it is likely something other than just tuberculosis. And TB and lymphoma look very alike. So we are not very sure what it is. But to diagnose TB, the best test would be a lymph node when available. The rest of all will not give us any etiology. And there is no contraindication of doing a lymph node biopsy. And it's easily approachable. So that should have been the first, and that could have given us a clear idea whether it's tubercle or not. If it is not tubercular, but again, Hodgkin's and TB lymphadenopathy histopathologically also may look very similar. And I recall on few occasions a child getting full 9 months AKT, but no big change. And there again, second biopsy, still TB, finally a Hodgkin's lymphoma. So, like we have a clinical differential diagnosis, and we are often not sure, even a histopathologist have a differential diagnosis. But what is most likely is what is put up on their report. So, I think lymph node biopsy would have been the best test. The rest of them, we are not sure. But even the albumin has gone down very fast. Edema has come up, all in a short period, which means that there is a very fastly progressive disease with not with nutrition not being able to maintain. And I think that's very unusual TB. Of course, TB we must rule out every time.
So how would you interpret the CSF report?
Pardon?
How would you interpret the CSF? 35 sugar, 57 or something proteins, right? 52 proteins and 37 sugar,
I think it's a non-specific.
48
In
cells.
fact, I don't see how disseminated TB like multiple lymph nodes is causing TB meningitis. The reason is lymph node TB is a localized disease, and that localized disease seems to spread to the meninges. That's unusual. So, if there is some irritation of the meninges, whether it's some autoimmune inflammation, not Kawasaki, but there must be other varieties of autoimmune disorders, and Hodgkin's is unlikely to cause that CSF of that kind. But I thought it was very non-specific. 37 sugar was within normal limits, 40 is normal, protein 50 is not very abnormal. And therefore, I feel that is of no conclusion. It's inconclusive finding. He did say that there is a neck stiffness, etc. But I'm sure that with a lymph nodes both sides, one could easily interpret neck stiffness, but not of a meningeal irritation, but a local irritation. So I think that's the best way to go back. But again, here we want to know next week.
How are you treating this child? You given IVIG?
Given IVIG
When was this child admitted?
2 days back.
Okay. So how are you all treating? Means what is your working?
Antibiotics are going on. Vancomycin and cephalosporin.
How is the fever?
Now the frequency have reduced.
Like
You've done a urine?
like lymph node went down and came up, fever also would come sometime, and fever also disappear. Antibiotic must not have caused reduction of fever, because which is infection? What infection are we talking about for us to get antibiotic working like that, right? So these are our impressions. Of course, we could be absolutely wrong.
Urine routine is normal. Don't know. And USG abdomen you've done, meaning okay. Fine. Let us know next time what happens. Yeah. I'll just check with the. So online audience, you want to come in? Any views? Any comments?
Sir, forgetting the past history of 1.5 months, if we take a small baby less than 5 years with history of fever and lymphadenopathy, occurred edema, strawberry tongue, and with markers, high inflammatory markers of CRP more than 300 and leukocytosis, thrombocytosis, and hypoalbuminemia, we can, and with the serial follow-up of echo, we can suspect KD in this setting. Because if we forget the past 1.5 months history, start with the 1 week history.
We've done 2D echo. It's normal.
It's normal, sir.
So,
but if periangle desquamation occurs after another 1 week, we can be sure that mostly we have dealt with it.
Correct. So the one point which Palni is making is today's 2D echo normal does not rule out Kawasaki. But Palni, the point is the biggest thing to consider Kawasaki is we will have to dissociate the first 1 month of the history totally.
Yes, sir. Yes, sir. Yes.
Yeah.
That
is the biggest. And then, of course, there are these odd points in the form of multiple lymph nodes and one more thing I thought of. So, but anyway, yeah, it's a general inflammatory response, and that previous illness we will have to discuss. So you have to look for more evidence. So like sterile pyuria, you have to look for a gallbladder on the USG. What does the gallbladder show? So these small things may add, but that initial 1 month we will have to then disconnect with this illness. Any other comments?
I think
Question?
lymph node biopsy would have been very, very indicative of this diagnosis.
Yeah, so they are planning it. It should happen maybe tomorrow or something.
Very interesting. Both discussions were excellent. Thank you.
Thank you very much, sir.
Thank you,
Thank you very
students,
Thank
for
you.
presenting.
Any questions from anyone else on the online platform? Okay, fine. So I think we'll stop the class here. Thank you. Thank you, everyone.